Welcome to this first PCR webinar on left main disease. My name is Emanuele Barbato and I'm interventional cardiologist at the Cardiovascular Research Center Aalst in Belgium and at the University of Naples Federico II in Italy. I have the pleasure today to have with me here in the studio Giulio Guagliumi from the Papa Giovanni Hospital in Bergamo, Italy, Alaide Chieffo from the San Raffaele Hospital in Milan, Italy, and Gabor Toth from the University of Graz, Austria. The topic of today is evaluation of left main, imaging and function. By the end of this 60 minutes webinar, we will try to achieve the following learning objectives. First of all, to understand limitations of the angiogram in left main disease. Second, to learn when and how FFR can facilitate the assessment in this specific setting. And third, we will learn when intravascular imaging becomes a must in this situation. To achieve this learning objective, we have selected two cases from our daily practice that we are going to share with you. Now, without further ado, I'd like to start with the two cases we selected for you. The first one was performed a couple of weeks ago in Aalst, and it deals with an equivocal, ambiguous image of the distal left main. It's an isolated disease of the left main. On the right side, you see the second case that was performed in San Raffaele Hospital in Milan, which is, from an anatomical point of view, a little bit more complex than the previous one, as beyond the distal left main disease, there are also two sequential stenosis in the mid-LAD segment. I would like now you to reflect upon the following points. When you see this image in your cath lab, the first reaction you have is call the surgeon. Rather, on the contrary, you would decide to do PCI and therefore you would ask for a stent. On the contrary, you need more information and you would rather prefer to do invasive functional assessment rather than intravascular imaging. Now, I would like to immediately start the discussion on these very interesting points and on these two images, and I would go now to Giulio. So when you see these images in your practice, Giulio, what would be your reaction?
Very challenging cases and very frequently seen on the tables. I think the decision is going to have a very significant impact also in terms of prognosis. So basically, when we are seeing these images, we wanted to have more information available. And the first reaction is to try to go in a different angiographic views to see this distal mid-sharp left main under different projection and to start to have the best visualization of the side branches and all these things.
Thank you, Giulio. We heard he needs, Alaide, more information. How about you? He needs more angiographic images. What would be your reaction?
Yeah, I think these are perfectly case of ambiguous left main. As you said, there are different scenarios. One, it's isolated ambiguous left main. The other, more complex, maybe also LAD is diseased. I think this is the perfect example underlying the limitation of angio, and I would go for further evaluation. You have to use your adjunctive tools if you have them available. And I would start, for example, in case one with functional evaluation, and then let's see which is the result, and if we really need other adjunctive tools, also imaging. But I would start with the functional evaluation in case one.
Thank you very much. Is there anything we didn't discuss so far, Gabor, that you would like to integrate?
Well, I completely agree with Alaide that these are ambiguous left main expressing very well the uncertainty of any decision based just on the angiogram. And especially for the second case, which is even more complex because we have left main, we have subsequential lesions in the LAD. We need definitely further more precise evaluation of the disease, and I would definitely go for functional evaluation in these cases.
Just a quick answer to the three of you. I don't know who wants to take this one. Would you continue with your diagnostic setting, or would you rather change to a PCI setting?
I mean, I would switch. I mean, when it's clear critical stenosis, okay, you have diagnosis. In this case, I would switch with the guiding catheter. I would take a couple of shots, and I would switch with the guiding catheter to have the wire down, and then to have the further evaluation. I would feel much more safe.
Hold on, let me just forward you, Alaide, this question that is pertaining to what you just said. The colleague is asking, in case of severe left main stenosis with tortuous vessel which need a strong backup force, how would you choose your guiding catheter and how would you balance the risk of deep engagement?
I mean, it depends on the anatomy. Normally, I go radial, so clearly I have some problems of support, but I normally use EBU catheter, extra backup catheter. No sidles, honestly, because I don't think it's needed. And as I said, I mean, if it's a critical left main, you have also the decision with your R team. So it's another scenario. So you take shots, you have diagnosis. So normally, unless it's an acute patient, you take the patient off the table and you discuss with your R team, because that's another point that is not the focus of this, but in that case, I would do.
Do you want to add anything else? I think in this case we are somehow facilitated that from the fact that ostial left main is not involved by the disease, and this is mostly located distally. But let's move forward. So you both asked additional information. Giulio wants more angio. You would like to integrate with invasive functional assessment. But let me provide you and the colleagues who are asking about the clinical presentation more information about these patients. Starting from case 1, it is a 67-year-old male patient, hypertensive, who presents with dyspnea, so it's a stable presentation. At the echo and MRI, this patient presents normal ejection fraction and left ventricular hypertrophy. This is the ECG at the presentation that shows clear T-wave abnormalities in anterolateral leads. On the angiogram, the right coronary artery was strictly normal, even if it is not shown here. These are the first two incidences I can offer you, AP caudal view and cranial LAO view. From the AP caudal view, we might perhaps suspect some disease at the ostium of the circumflex. From the cranial LAO view, we see again the image I showed before with this ambiguous lesion of the distal segment. Here are other two angiograms, the RAO caudal and the spider view. And I'm curious now to hear what is the opinion of Giulio, and this question goes to you. With this clinical picture and having seen more angios, can you take your decision now?
I'm still challenged. I'm still challenged because the symptoms, they are not typical for chest pain. I'm challenged about the hypertrophy with the AKG changes, despite the fact that we use multiple views and probably a lot of contrast. We still have a lot of insertness of the ostium of the circle, that is a big vessel. So I don't think that we are still at the time when we can make a reasonable decision for this patient based upon the data we have.
Thank you very much. Perhaps, Alaide, I can integrate the question to you with one question coming from the colleagues. Is there anything we could improve in taking the angiogram of the left main? You alluded to the decision to take the guiding catheter. The colleague is asking, do you have an algorithm you might want to share with us in your practice in choosing the catheter size? When you would go for a 6 French, when you would go for a 7 French? I mean, can you share your tips and tricks?
Yes, I mean, in this phase and in both cases, I mean, if they are critical, it's going to be provisional stenting. Synta score is going to be low. So theoretically, this is one of the indications for PCI left main. So guiding catheter, in this case, 6 French, because it would be a provisional stenting. And only, I have to say that in most also of the cases where there must be a 2-stent strategy, I go with the 6 French, because most of the 2-stent strategy can be handled by 6 French. 7 French for me is just indication of some specific 2-stenting technique, or if you have really to use multiple wire and you are going to use imaging or rotablate, and you maybe have to upgrade your rota wire. I mean, so mostly it's a 6 French guiding catheter.
I see that Alaide is really in the PCI mode and PCI mood, as she's already speaking of PCI strategy. But Gabor, let's go a step back. We still have to take a decision. We see that Giulio is still puzzled by imaging. Is there anything else you want to add?
Yeah, I think it's very nicely indicated by this multiple projections that in case of left main bifurcation, you need to adapt your projections to that very given case. You cannot, mainly you cannot take your standard projections. You need to find the best projections to see the bifurcation, the ostia, and so on. But what is really important, and I think it's really important to remember this after this session, that even if you achieve the best achievable angiogram, then there is a certain remaining uncertainty in terms of lesion severity. Why? Simply, we have good registry data suggesting that if you simply take the 50% diameter stenosis cutoff for angiographic appearance, then at least 1/3 of the lesions will be misclassified. Meaning, due to this functional anatomical mismatch in case of left main, 1/3 of the patients will be either overtreated or undertreated if you purely rely on the angiographic appearance. So I'm convinced that you definitely need further evaluation before you go for any kind of treatment or deferral.
Thank you very much. I think I can just summarize this first part saying that whatever we do, we will never make happy Giulio by adding more angiograms. So I think we can agree that in this specific setting, coronary angiography will not provide us with a definitive answer to our important clinical question. We need more information, we need more investigations, and I understand from Alaide and Gabor that your preferred diagnostic assessment at this stage will be invasive functional assessment, and that is actually what we did in this specific case. Let me progress with the slide. What here we have done is placing the pressure wire first into the circumflex. We have induced hyperemia and we measured an FFR of 0.91. Then we moved on and we placed the pressure wire into the LAD, measuring then the left main LAD obstruction to the coronary flow. And here we measured an FFR of 0.83. Now, this is what we have seen so far. We have FFR of this left main. What to do next? And I will start with you now, Gabor. Would you stop the procedure at this time and based on the angiogram, together with the invasive functional assessment, defer to optimal medical therapy these patients, or would you rather do something different?
You know, Emanuele, I really like the way you perform this diagnostic assessment, functional assessment of this left main disease. You measured circ, most probably in the very distal circ. You measured LAD in the very distal LAD. In this way, you get a full functional mapping of the left coronary system, including the left main and all potential bystander lesions or narrowings. I'm convinced once you measured FFR in circ and LAD not reaching the 0.80 cutoff, so both measurements are above this 0.80 cutoff. So I'm convinced that in this way it's confirmed that this left main is not inducing any hyperemia in this very case. But may I also ask, how did you perform the FFR measurement? Did you use intracoronary adenosine or IV adenosine? It's a quite often question what we receive.
Well, it's an important one. In this specific case, we did a very quick assessment with IC adenosine. I gave 2 times IC bolus, and the effect of having in both situations an preserved fractional flow reserve value made me happy with this assessment. What would you have done differently otherwise?
I would just do the same and the SAID with this normal or not significant FFR values. I would just stop the procedure here and go for medical therapy alone.
Okay. So Alaide, we heard from Gabor, he's happy with the assessment. He would now stop the procedure, so he takes an important decision actually, and he would defer the patients to optimal medical therapy. Are there data supporting his decision?
Yes, you know, unfortunately we don't have randomized clinical trials specifically addressed to evaluate FFR in unprotected left main. So what we have is extrapolated from randomized clinical trial in non-left main population what we have in literature are retrospective registries evaluating deferring left main intervention with a cutoff of 0.80. So this is the evidence that we have so far.
There is a question there. I will quickly answer it. Why not IFR? Simply because I don't have this tool in my cath lab. Yeah. So I would say, why not? You can use that if you wish. But the question I have to Giulio is the following. We've heard that they seem to be quite happy with this assessment. So I have a double question to you. First, would you have started with invasive functional assessment at all, or would you have considered something else? And if you would have started with functional assessment at this stage, would you still perform something more, or are you aligned with the other two colleagues?
So practically speaking, in my lab, seeing this case, you can do both. You may start by using FFR, and we are trusting on the reliability of this data, or you may start also by using intracoronary imaging, because we know that differently from all the other segments of the coronary tree, in the left main, FFR and intracoronary imaging are very aligned. Means they are quite both reliable. In fact, also in a bigger study like Excel, the decision was made based upon a critical stenosis assessed in terms of minimal cross-sectional area or minimal lumen area, or a cutoff value of the FFR below 0.80. So I think that we can start with both. Coming back to your question, what to do now? Today I'm playing the role of the skeptical guy. And Alaide was mentioning that we do not have any absolutely solid data. We have reliable data, but they were not prospectively done. I know about how much there are alignment between function and images. So to be really sure about the final decision, also considering the prognostic impact, I wanted to go ahead with some additional information by using intravascular imaging.
Thank you very much. I have a number of questions. Perhaps we can quickly try to address them before moving on. There is a specific one on the role of IVUS about how to best use it in ostial left main. But if the colleague has some patience, we can address this later. There are a number of questions on FFR. Perhaps Gabor can quickly help me to address them. First, at dose of adenosine, I used in my case 200 micrograms for the two boluses I see. Any different opinion on that from your side?
The best data what we have from dose response analysis is that 200 micrograms for the left system is the sufficient dose. Further increasing the dose doesn't bring any more maximal hyperemia, so with 200 you can already reach the maximum. Of course, you have to be sure that the adenosine is injected in the coronary, so for the injection you should engage the guiding if you use intracoronary, or if you are not sure, you can engage your guiding well. Then the safest and most reliable way is simply to go for IV adenosine.
Next, it's about the cutoff of FFR in left main.
I said we have no data to support any other cutoff than the 0.80 what we use for any other lesions.
Quick question to you. We said there are no randomized trials for FFR in left main. There is a colleague asking again, why not IFR? Are there data there?
Randomized clinical trial, not yet. I mean, there are.
Are you aware of registries of IFR in left main, Gabor?
Personally, I'm not.
Okay, not even myself. So I hope we made happy this colleague. And then next, in case your patient has heart failure, of course, we put in the presentation dyspnea, but we, of course, specified also that the patient has preserved ejection fraction. So we might have, at the max, diastolic dysfunction. FFR is good. What do you think? I mean, any opinion about that, FFR in heart failure patients?
Well, what we know, we have, again, good data to support that increased right atrial pressure or central venous pressure does not have any clinically relevant impact on the reliability of the measurement. So if we translate this question in this way, whether in a patient with an increased central venous pressure due to heart failure, whether we should change our cutoff or not rely on FFR, then I can I can say that we have good data supporting that FFR is reliable also in these clinical settings.
Okay. I think we are well set, and I can just wrap up what's been discussed so far. I wouldn't say anything wrong by stating that we are comfortable in taking a decision based on this FFR assessment, at least from Alaide and Gabor. But given the good agreement between function and imaging, specifically left main, I think it's also fair to say that we might want, given the prognostic importance of this decision, to complement the diagnostic workout by integrating the diagnostic assessment also with imaging, like Giulio was fairly stating. And in this regard, we can move on with the case, and I would really need Giulio's feedback here. Can you comment on these images?
Okay, this is the typical display you have on your screen at the end of the entire pullback. On the upper panel of the left, you have the angio with a small white dot that is moving back. That is exactly the marker that you have below, and is telling you after the synchronization what you have on angio and what you have on the right panel in the cross-sectional area. So there is a precise correspondence between the content and the envelope. And here you might say that below you have a different type of setting. You have a longitudinal view, and then you have in the middle part of the screen, you have a sort of a cartoon. This cartoon is very important because it is depicting the automatic lumen detection board. Each cross-section is going to be measured in terms of area and display as the longitudinal view, but in 360 degrees. So what is essential? You have here synchronization between angio and OCT, and you have measurements. And the measurements are telling you that the distal left main that we are crossing now has a maximum of 40% of percentage stenosis with an area that 506 millimeters square. If you are going to the next, probably, here we can sum up the essential of this imaging pullback that was done in both vessels. They did with FFR, they did the same with intracoronary imaging, from Alaide to the left main and from circ to the left main. And one of the questions could be why they did it this way. Because sometimes your guide wire is not centrally placed. And so if you wanted to be very precise in terms of assessment and minimal cross-sectional area on the left main, you might do with both acquisition. Here you might say one section from the proximal Alaide, that in any case is more than 4. Then we are going to see the minimal lumen area at the level of the distal left main, that is a little bit more than 5. And then you may see the proximal part of the left main that is huge with a 12 millimeter square. Going to the other pullback from the circ, again you can see the correspondence between more or less the two pullbacks at the level of the distal left main. You may see that at this point is 30% of residual stenosis, and with one cross-sectional area that is in any case quite proximal to 6. And here you have the full assessment of the proximal part of the left main with a big area of 12. This is the essential information, so synchronization of angio with imaging, and essentially provide automatic measurements to make the decision possible.
Thank you, Giulio. Can I just abuse of your experience and knowledge in imaging in addressing the questions that have just come from the colleagues? Can you tell us about reference cutoff values in terms of MLA for OCT and for IVUS? When would you define significant left main stenosis based on these imaging techniques?
So mostly we say that mostly in left main the people are using IVUS. This is based upon the evidence, and so huge amount of work that was done. The essential from this data are, number one, the minimum lumen cross-sectional area is based on the population. So for Western people, the most approved in terms of eye sensitivity and a negative predictive value is 6 millimeters square. For Far East population is much below due to the size of 4.5, but is less proved. So let's stay with the Western population and move from IVUS to the OCT. Simply, we don't have enough data to say that today. We might suggest a cutoff value for critical stenosis based upon the OCT. These data need to be collected.
Thank you very much. Gabor, we know that Giulio is, allow me the joke, the Pope, one of the Pope of OCT. But I'm interested how a common person, a regular interventional cardiologist, would try to optimally acquire OCT in left main. I know that there are challenges there, so I'm really interested to hear from you. How would you do that?
Yes, for regular cardiologists, it can be challenging to perform such nice OCT images in case of left main, and it definitely requires some practice, I would say. But I think the key of achieving nice images is the perfect clearance of the lumen and how you can achieve it with well-engaged guiding. In case of really large left mains, sometimes we decide to take a 7 French guiding to be sure that we can achieve nice clearance. And even like that, you can achieve nice clearance in the distal left main, in the bifurcation, and in the ostium of the side branches. But as you might have noticed in this recording as well, you cannot really make good images of the left main ostium. So if your question is left main ostium, as regular cardiologist, I would not go for OCT, but I was for distal left main and bifurcation. I think nice images are already achievable.
Manuel, let me add just a few words about the short shaft, the short left main. I think this is another no indication for OCT. So not only lesion at the ostial position, but if you have a very short left main and you needed to engage, you're just overcoming the left main and you cannot get any type of reliable measurements.
Yeah.
Alaide, I want to hear your voice. OCT has been done.
The average cardiologist in a not average cath lab, I would define myself. So
what would you have done in this case? OCT as well or another imaging technique?
Honestly, I mean, there are two options. To stop really at the functional assessment, because it's an ambiguous, clinical symptoms were not so clear. He has also hypertrophic cardiomyopathy. Or in case of imaging, because it was 0.82 and it's a young patient, I would go for IVUS, honestly. For all the pitfalls that they were addressed.
Okay.
And also because in case you have to intervene, for me it is the best guidance for intervene and to guide your procedure.
Okay, I see that Alaide's hands are always itching. She is always prone to treat. Let's perhaps use this time that we saved. We are in a good shape. There are some questions that we might want to address before wrapping up the first case. The first question is for you, Giulio. Do you think that cardiolite or PET study is required in this case? I don't know if you have an opinion on that.
I'm sorry to disappoint in you. I don't think you have a strong opinion. And I think that is out of my experience. I don't want to make any type of suggestion about that.
Not in my experience, so I would spare you this question unless you have an opinion, Alaide.
I mean, I don't think this is the perfect case for PET. I mean, you can get the diagnosis in the cath lab in this case.
Okay.
I think
you made a very important point. Why to take the patient out of the cath lab and not complete the diagnostic assessment with the tools that we have at our disposal today? Next question, I guess, is for me. Have you injected nitroglycerin before adenosine? Yes, always, even during the diagnostic assessment with coronary angiogram. I think we already discussed about the dose of intracoronary adenosine. With having said that, I think I can wrap up this first case. Don't leave, because we have a second very interesting case. And we can say that here we saw applied invasive functional assessment with fractional flow reserve. that showed a preserved value. So in this case, we felt comfortable to take our decision, even though we complemented the diagnostic assessment with what we heard that might have been the pitfalls of invasive functional assessment by performing OCT that nicely confirmed and reinforced the decision that we have taken based on the invasive functional assessment. I think we are now ready to see the next case. Let me move to the following slide. Here we have an elderly patient, not like the previous one, 80 years old in the case of Alaide, hypertension, presenting again with stable angina. We have an additional view to the one we have seen before, the areocaudal view on the left, that shows this pinching of the distal left main, and on the epicranial view, again, we see this lesion that honestly, looking at the angiogram, looks to me already significant, at least if I compare it to the previous one. And to make the things a little bit more complex, there are these two additional lesions downstream. So let's start again our exercise. I would ask you, the colleague from home, I would invite to reflect, and the colleagues here in the studio, can you take your decision at this stage, Gabor?
Well, to summarize, definitely not.
Definitely not.
As discussed at the beginning, of course, as compared to the first image what we have seen at the beginning of this session, we performed, Alaide performed here other projections to have the best view, but still from these more views we just understood the complexity of the case. We have the bifurcation in the left main and the subsequential lesions in the LAD, actually 2 tandem lesions in the LAD. So I definitely need more information in such cases. And again, I would start with functional evaluation. And even functional evaluation in this case would be even more complex as compared to the previous case. It's definitely important to measure both circ and LAD. In case the circ is negative, then we will understand, and the LAD is also negative, then for me it's clear, then the LAD lesions and the left main are even in some not ischemic, so there is nothing to do. If the circ is negative and the LAD is positive, then we need to understand what is let's say, what is the role of the individual lesions to generate this summed ischemic potential. And to understand this, what we can do is a pullback FFR measurement under maximal hyperemia. And with pullback, we can really individually evaluate each lesion, mid LAD, a bit more proximal LAD, and the left main. In this way, we can really understand which lesion or which lesions are responsible for the ischemia in the LAD territory if the sum is measured as significant.
Can I hold on what you just said, because I have an interesting question that perfectly fits within your reasoning. How do you think for general administration of adenosine versus intracoronary, basically, what would be your opinion about intravenous systemic infusion of adenosine versus intracoronary infusion of adenosine in this case?
Well, if we just want to understand the ischemia in the LAD territory and we want to get one single value for the whole LAD, then intracoronary is perfect. It's quick enough, and then you get one value. If you want to evaluate one by one the lesions, so you want to perform pullback, then you need continuous hyperemia, which lasts as long as you want to last. And this is only achievable by IV. IV adenosine, you switch it on, you see the plateau, the hyperemia, and then you maintain this hyperemia as long as you perform the pullback, and you evaluate each lesions one by one, and then switch it off. So in this way, you had stable maximum hyperemia for the whole pullback. It can be done only by IV adenosine.
Now, going to you, Giulio, the same question that I made to Gabor. Are you happy with this angio? Would you be able to take a decision at this stage? And if not, I'm interested to know what would you do indeed?
I'm not sure, having this patient on the table, we will do differently from Gabor. I think that there are two challenging aspects. One is the multiple lesion on the LAD, and so probably we are going to assess in the same way by having IV infusion of adenosine and a clear cat pullback to understand the different gradient of all lesions. But of course, you may see the circuit is very big, so we needed to have a precise sizing in case we are making the decision about the left main. So I think that imaging might help a lot in getting the full information available for deciding what to do and how to do it.
That's a good point. There is a question there before we go to Alaide. Let me just read. Well, one question is again about adenosine administration. There is also this option of administering intracoronarly the infusion of adenosine, which is an option. There is a dedicated catheter that has been validated. Why not? That could be an option, and you would spare the systemic effect of the intravenous infusion. There is an interesting, intriguing question on IVUS, on imaging, basically, and I would prefer Giulio addressing this. What would you do in case of discrepant result, controversy between function and imaging? If FFR tells you that it is not significant, for example, and IVUS tells you that it is well significant, what would be your reaction?
Well, number one, this situation is not frequent. We saw the previous case where we were perfectly aligned because we had a minimum cross-sectional area that was between 5 and 6, that is the gray zone, and we saw that having this integrated information, we were able to confirm the decision. So normally there is a very significant line. The mismatch is depending, in my view, on the situation. I think that in any case, we should take into account the interest of the patients. I think that if we have something that is more pushing toward the procedure, we have the patient on the table and we have true limits, minimum cross-sectional area at the distal left main, we should consider. So I think that this is my personal position.
Do you have an opinion on this, Gabor, about mismatch between imaging and function?
Well, I see it in a way that you do an additional diagnostic step in case some hesitation is left behind. So let's say if you measure an FFR value which is very close to the cutoff and you are really just not sure whether it's over or beyond, then you perform an imaging and then it will either confirm one or the other. So every next diagnostic step will be done to clarify it further. So I see in this way that if you perform an additional step, then this will guide you towards treatment or not, in case there was some hesitation based on the first one.
There are, in the meantime, some other questions coming, but I guess we would now be interested in what you did, Alaide, in this case, please.
Okay, so what we did is to start to evaluate the LAD with the FFR in order to evaluate the different stenosis, tandem stenosis that we have on the LAD, and no better way than functional evaluation. So we started distally, FFR was 0.78, then in the distal part, but more proximal, 0.83, and in the proximate part 0.84, but what was important is then from the 0.78 distal and the proximal distal of 0.83, the delta was 0.05, and in the proximal part only 0.01. And then we did also IVUS. Honestly, in this case, if it was only LAD, most probably we would have stopped here. In this case, there was the interrogation of the left main stenosis that I agree must be intermediate critical. So because of what I was saying before, that in guiding PCI left main, I think that still IVUS has more evidence. We did also IVUS. And as you can say, in all the three locations and stenosis, the area was more than 4.0, which is the cutoff, and also the plaque burden was not significant. Then we went to evaluate then the left main, and by FFR distal 0.84, and we went to proximal 1.0, but the delta was 0.16 in this case. So it seems that the symptoms of the patient, which was really low effort angina, must be provoked by the left main. Then interestingly, at the IVUS, and this is one of the cases and the question that was posed before, we have here a 6.49. So what do you do now? Actually, the FFR is significant, Giulio, and then the IVUS, not so much.
Perhaps we can start from Giulio, given this challenge from Alaide. Can you comment on these IVUS pullback in the meantime?
So the first imaging we saw, let me go back in a second. So these are the images I was referring. She was watching to the Alaide, and the main message was substantially in line with the FFR. The plaque burden is no more than 50, and the luminal area is more than 5 everywhere. This is reinforcing the decision that Alaide did. Then, when we went to the IVUS, so the most important information is not only in a minimum lumen area, but to get the guidance eventually for intervention. You can see 3 clear examples of how we are using IVUS for guiding the procedure, the PCI procedure. In the upper part, you might see a proximal left main cross-sectional area, where you can see that number 1, there is no plaque. Number 2, the vessel diameter is 4.5. You are going to be guided in the selection of the stent. Then you have below where to land, because if we are placing a stent, we need to decide where we're landing with the stents. And you may see that at this point in the cross-section below, number 1, you don't have lipid plaque. Number 2, the plaque burden is quite limited. Never land a stent in a very fragile lipid-rich plaque or echoic plaque, and never land one stent when you have a plaque burden more than 50. So in addition, we decided for sizing, we decided for landing, and you may see also information about the lesion lengths. So you can take advantages of these measurements for being guiding during the procedure.
And now, Gabor, can you comment on the FFR pullback, please?
Yes, so this pullback demonstrates very nicely the different step-ups all over the different lesions, and you have shown very nicely that the mid-LAD lesions cause only minor pressure gradients, and the biggest pressure drop is located actually in the left main. But this, let's say, discrepancy here between the left main measurement and the LAD measure and the left main imaging measurement and the left main LAD functional measurement demonstrates also nicely how the FFR measurement in the distal LAD gives you a kind of longitudinal understanding of the whole vessel, incorporating everything between the guiding and the sensor, while imaging gives you high quality information on the very spot where the imaging is located. So here you have seen in the left main there is a 0.16 drop of FFR located. This has the major role in the ischemic burden of the LAD territory. If we decide for treatment, and I think we decide for treatment, this is what we have to treat. But actually the significant FFR comes from the sum of left main LAD and the second LAD lesion together. This is why it's important, after treating the left main, re-evaluate the LAD once more to get a clear understanding of the true ischemic potential of the LAD lesions as well.
This allows me to reconnect to one of the questions in tandem lesions that you have addressed by just discussing this. So this one we can consider it as addressed. Let me stay on you, Gabor. Any experience with other hyperemic drugs? Because apparently in the country of this colleague, adenosine is extremely expensive. Any experience with papaverine or regadenoson or whatever?
So papaverine is tricky. With papaverine, you can achieve very nice hyperemia, but you have to be very, very careful if it's mixed with contrast. If you are flushing with a kind of mixture of, by accident, a mixture of contrast and papaverine, it can induce malignant ventricular arrhythmias. So this is why we are not using it at all. And to be honest, I don't have much experience with regadenoson. What I know about that, with regadenoson, you can achieve long-lasting hyperemia with one bolus, but it's quite unpredictable how long it lasts. It can have a variability between 10, 15 seconds to even minutes. So you do not really know in advance how long the hyperemia will last in that very patient. So this is why I think it's not really in the common practice.
How about simple contrast injection?
Yeah. I was
Alaide,
coming with
please.
this because, you know, at the end, because you can have also patient where actually it's contraindicated adenosine. So it's a small proportion of patient, but you can think about that. I do still remember to a diagnostic case that we did with the severe aortic stenosis for a cardiac surgeon. And the fellow decided to go with FFR because of ambiguous left main, and the patient shocked.
Okay.
So, I mean, there are some cases. So in some specific case, we try to do just contrast injection. There are very small series, we have to say. There is a small series validating just the contrast injection, doing FFR with contrast injection. They say that it can be validated with the adenosine FFR. Clearly, this needs further data.
Yeah.
But if you have nothing other available, that can be maybe a possible solution.
So I can tell you we have a quite simplistic practice in the lab. We place the wire. It's true for left main or any other lesions. We place the wire, and if this gradient, what see at the beginning, it's below 0.80, then FFR will be definitely below 0.80. Then you flush contrast to justify the position of the wire. If by this contrast you induce a gradient below 0.80, then FFR will be definitely 0.80. And if not, then you measure with adenosine. In this way, actually, you need to measure through adenosine-induced FFR only, I would say, in 40% of the cases.
There is one question from a colleague who says, in this second case, let's go straight to the discussion of which stent technique in light of the angio image guided by IVUS. Perhaps, Alaide, since we spared some time, we can go through the case and really understand the way you manage this patient.
Okay, so I do think that with the IVUS, I mean, we didn't do, I have to say, pullback in the circumflex, but when we were pulling back from the LED on the left main, we were able to see also the ostium of the circumflex that was not disease at all. Clearly, something else should be to go to do the pullback from the IVUS, but because of the angio and because of the IVUS image that we got through the pullback from the LED, we really did think that this was a Medina 110, and so clearly this is a bifurcation lesion, but this is an indication for provisional stenting, and I don't think there is a discussion on that. It was a new generation drug-eluting stent, 3.5. I mean, we saw that media to media was 4.5, but we know, and this is sometimes a pitfall, that sometimes you can oversize your stent by IVUS. We have a long experience with IVUS, and we have this in mind. And you know that you can always post-dilate this kind of devices. It was post-dilated a little bit, I have to say, gently with the 3.5, 22 atmosphere. It was done a kissing balloon inflation. But then, and this is the importance of the imaging, so angiographically, it looks fine. What do you think? Would you stop here or do something else? I mean, what we have learned is to do an IVUS in this kind of cases, and this is the IVUS evaluation. So distal edge, no edge dissection, no malopposition. Excellent result of the kissing balloon, well-open circumflex ostium, circumflex ostium covered with membrane stent struts. But then there was this ellipsoid morphology in the left main from the lower panel. And that's the important point that you could not see at all by the angio because there was this proximal edge malapposition. Stent diameter 3.53, lumen diameter 4.40.
Perhaps it would be interesting to hear Giulio at this point. Can you make a comment?
Once again, challenging because we were watching to the proximal left main size and we say the 4.5. But then we were watching to the proximal Alaide and we say that we need to decide for landing. And the proximal Alaide after a bifurcation is clearly much less in terms of size compared to the left main. So we needed to take into account both. And probably especially we needed to be focused on the distal to avoid it to have dissection. They decided to go with a last generation stent that can be nicely, gently, but overexpanded compared to the original size. And now we have the evidence not only of the use of the IVUS before the stent implantation, but how to use the IVUS at the end of the implant. Angio seems good. But you have a huge malapposition based upon this 3.5 that was based on the distal landing, and approximately there is a larger malapposition. So I suppose that
some action.
Alaide react immediately.
Yeah, some action needs to be done, I think. So additional post-dilatation with a larger balloon. It was used, clearly you have to pot, because that's another important point, because the provisional needs to do proximal optimization that was done. We can discuss if you have to pot initially and then repot, because this is by European Bifurcation Club. In this case, it was done a pot with a 40-24 atmosphere. It's important the position of the balloon, because you have to spare the bifurcation. So the real proximal optimization is in the body of the left main, not in the bifurcation. And you can see, and maybe Giulio, you can comment, the image before, the post-dilatation with the proper size and the proximal optimization, and then the result after the proximal
So we must convince everybody that you don't need to be an expert to see a huge malapposition, and after having fixed this malapposition with one single action that taking a large balloon, high pressure, non-compliant. So it's a very simple. This is a story of the difficulty in imaging interpretation when you are propping in imaging quality is much clearer compared to what is the rumor. So I think that everybody can clearly judge this imaging and this measure.
No, provisional is the simple strategy. So be simple, but sometimes not to be too simple. You know, that's I think
that's fairly said.
Yeah.
Can I extend to you a question from our colleagues? What is the rationale for kissing in this case? Is part of your routine practice?
You know, this is very debated. Even in the randomized clinical trial, it is very debated. There was a first randomized clinical trial from the Nordic series, not so clear because it was negative, but then when I went to the true bifurcation, it was positive. There was a most recent one, more positive. I mean, it's our practice when the circumflex is so big. And it supplies a large territory. We do kiss also because clearly this is an 80-year-old person, but if you do have further action then to be taken in the circumflex, at least you have opened your struts toward also the circumflex. So in this kind of case, it is our practice because what is driving our procedure is the importance of the side branch in this case.
That's a good point. There are a number of questions related to function, Gabor. I think the most pertaining one is we have done our treatment now. We are in the setting of sequential stenosis, and the colleague is rightly asking, do you always check FFR after treating your culprit lesion?
Well, I would say optimal is when you check it always. Of course, sometimes it's not feasible. There was a contrast load, or your wire is destroyed already. You cannot use it. There are cases again and again when you decide for good reasons not to do that. But if you can, if it works, why not? Then you really get an information where you started and where you end, what the patient benefited from your procedure. you can express it. And in such cases like here, as discussed at the beginning, there are additional lesions which were considered angiographically at least intermediate or uncertain at the very beginning. They are still there. And now that we eliminated the one with the biggest step up, there is this functional crosstalk between lesions, sequential lesions. So if you want to get a clear idea about the functional relevance of the downstream stenosis in the Alaide, then I would say yes, you should go for a second FFR measurement to assess where you are now after treating the left main.
And if you can just go on and quickly elaborate on IFR, the role of IFR in this case. There are a couple of colleagues saying that this might be exactly the scenario where IFR pullback might be useful. Do you have an opinion on that as well?
Yeah, there are concepts suggesting that in case of so-called resting indices, then this crosstalk might not be that big issue. Still, I think the value of post-PCI FFR or IFR measurement is really to understand where the patient started before the procedure and where we get here. If you have a final FFR measurement of 0.82 now, maybe you decide not to treat the Alaide, but you know this patient goes home now and FFR 0.82 territory in the Alaide region.
I think I want to close this series of questions with Giulio. And I want you to really give clear words, because we have a fundamental question from one of our colleagues. And I would like to rephrase it like this. Can we obtain what we have achieved so far in terms of diagnostic informative content, in terms of PCI guidance, with simple coronary angiogram, without having any adjunctive testing? The colleague is asking, the usual challenge we face in many cath labs, there is either no IVUS, no FFR, I assume also no CT. Could you take a decision now?
Well, now I'm more puzzled than at the beginning, because you say that take out everything that we have today for decision making, and let's try. So I think that we wanted to highlight that, first of all, the left main angiographic assessment is very subjective. And so when you have a clear-cut lesion, marginal or extremely severe, you cannot decide by yourself. But in many of these cases, you cannot do it. And so you need some additional tools for answering prognostically is too much important to try to answer properly to this question.
Thank you very much, Giulio. I think it is now time to conclude this webinar that was dedicated to the evaluation of the left main stem imaging and function. I think we have convinced you by now, and these are our take-home messages, if I can go in the right direction. We convinced you about the limitation of angiogram in left main disease assessment, on the need to integrate the angiogram with additional tests, and we also learned how to optimize the combination of the two, and what can we do by extracting the best of the two technique. With this, and on behalf of my colleagues who kindly joined me here today in Paris, I would like to thank the PCR team. You can imagine behind the screen there is plenty of people helping us. I would like to thank Medtronic for the unrestricted support provided to this series of webinars. And I would like to invite you, of course, to join us to the next webinar of this series that will be performed in the cath lab of the Cardiovascular Research Center in Aalst, and it will be, guess what, dedicated to a PCI of the left main. Thank you very much.